Bismillahirrahmanirrahim. Hello friends. So here we have another question. So we stated that a 39-year-old woman, gravida 4 for a 0, gravida 4 for a 0, abortion 3 at 35 week of gestation, come to the hospital due to intense constant lower abdominal pain. The patient conceived via in vitro fertilization. Her prenatal courses has been uneventful. Over the past 10 years, the patient has had 3 miscarriages, all attributed to the uterine leiomyoma. 2 years ago, she had abdominal myomectomy for removal of 15 leiomyomas, during which the uterine cavity was entered. Pelvic examination shows cervical dilation of 4 cm. The patient contraction occur every 2 to 3 minutes and lasts for 45 seconds. The fetal heart rate tracing shows a baseline rate in the 140s with moderate variability and persistent variable deceleration to the 90s. Which of the following is the best next step in management of this patient? Choice A, expectant management and spontaneous vaginal delivery. Choice B, intrauterine pressure catheter and immunoinfusion. Choice C, intravenous administration of terbutaline. Choice D, laparotomy and delivery. Choice E, operative vaginal delivery. So in this question they are asking that the patient have in the past 10 years the patient has constant 3 miscarriages, and which all all 3 miscarriages are attributed to the uterine leiomyomas. So 2 year ago she had an abdominal myomectomy. So first of all we have to highlight this point: abdominal myomectomy for removal of 15 leiomyomas. This is very huge leiomyomas, and with the uterine cavity was entered. Uterine cavity enter mean that leiomyomas this, for the surgery of leiomyoma, the uterine cavity was also entered. This is the second hint in the question. The third hint is that at this time the pelvic examination shows cervical dilation of 4 cm. This is the third hint, with variable deceleration, constant deceleration 2 to 3 for 45 minutes, and the fetal heart rate tracing is 140s, persistent variable deceleration. So let's revise again. A 39-year-old woman, gravida 4 para 0, abortion 3 at 35 week of gestation, come to the hospital due to intense cervical constant lower abdominal pain. She had previous surgery for leiomyomas, and with the uterine cavity was entered, and on that time the pelvic examination shows cervical dilation of 4 cm, and the fetal heart rate is 140s with variable and persistent variable deceleration to the 90s. So which of the following is the best next step in management of this patient? So first of all I will write here that what are the hints in this question. So first of all, intense constant lower abdominal pain. First of all we have to go toward the diagnosis. After the diagnosis we will easily know that which of the following option is the correct one. So first of all, intense lower abdominal pain, intense lower abdominal pain. This is the first hint. The second hint is that the 2 years ago the patient had surgery for the abdominal leiomyomas, for which the surgery is myomectomy. And on that surgery the uterine cavity has entered. The leiomyomas has entered the uterine cavity. Uterine cavity was entered. This is the second hint. The third hint is the cervical dilation. On that time, on the pelvic examination, the cervical dilation is 4 cm. Cervical dilation 4 cm. This is the third hint. The fourth hint is the fetal heart rate tracing. Fetal heart rate tracing is 140s with rapid deceleration in the 90s. So this is the 4 hint. So based on the 4 hint, as we already know that what is the that what at this time what the female patient or what is the the patient is suffering from. So we as we can already we can easily know that this patient is suffering from uterine rupture. So first of all, how is the uterine rupture? First of all, intense constant lower abdominal pain. This is the first one. The second one is cervical dilation 4 centimeter. The third one is the fetal heart rate is in the 140s with rapid deceleration to the 90s. So these three hints are, so based on these three hints, the diagnosis to this question is that the patient is suffering from uterine rupture. So in case of uterine rupture, we have to go toward the emergent laparotomy and delivery of this fetus. So the choice D is the correct one, laparotomy and delivery. So why the choice D is the correct one? So if, for example, if the patient had previous low transverse cesarean delivery or abdominal myomectomy without uterine cavity entry, then vaginal delivery is possible. But if the patient has classical cesarean delivery or abdominal myomectomy with uterine cavity entry, then delivery via vaginal is contraindicated. Okay, this patient previous myomectomy, intense constant abdominal pain and abnormal fetal heart rate tracing are concerning for uterine rupture. So in such cases, urgent laparotomy and delivery are required. So the choice D is the correct one. Why the choice is incorrect? Expectant management and spontaneous vaginal delivery. Because expectant management for a vaginal delivery is generally contraindicated in patients with prior classical cesarean delivery or extensive myomectomy, as this patient already has the extensive myomectomy and which the uterine cavity was entered. So this is contraindicated. The choice B. Why the choice B is incorrect? Choice B, intrauterine pressure catheter and immune infusion. So immune infusion is the placement of an intrauterine pressure catheter for an intrauterine infusion to decrease umbilical cord compression and resolve variable deceleration. So immune infusion is contraindicated in patient with a history of uterine surgery. Let's come to the choice C. Choice C, intravenous administration of terbutaline. As we already know that what is terbutaline? Terbutaline is a tocolytics. So what the tocolytics mean? Tocolytics mean to relax the uterus. But this patient this patient contraction are normal, as this patient contraction occur every 2 to 3 minutes. So this is normal contraction, so no need to administer intravenous terbutaline. Come to the choice E, operative vaginal delivery. So an operative vaginal delivery can be used for a vaginal delivery in patient with abnormal fetal heart rate tracing. However, patient must be completely 10 centimeter dilated cervix. The operative vaginal delivery in such cases we cannot perform because this patient's cervical dilation is of 4 centimeter, and we can perform the operative vaginal delivery when the cervix is dilated to 10 centimeter. So this is also incorrect. Let's